So there are a lot of arguments to operate. First, macular edema. Second, a decrease of vision. And in addition, you can put on that the fact that there is a epiretinal membrane. So this happens very often, that referring ophthalmologist sent you a patient like that, asking you to operate the patient. So what do the panel you will do in such a case?
I think it's not a clear lamellar hole, because you have all the photoreceptors in the bottom of the hole. There is no thinning of photoreceptors. And for me, a real lamellar hole has a thin, very thin layer of photoreceptor in the bottom. And those holes, I never operate them because they will finish with macular hole or no visual improvement.
If there is an edema, an additional edema and an epiretinal membrane.
So
if there is an epiretinal membrane, it's a pseudo-hole, because pseudo-hole are just verticalization of the foveal contour due to epiretinal membrane, different spot around the hole. So this is the difference. So if there is a thickening of the retina around the fovea, is a pseudo-hole. So a pseudo-hole is just a modification of the foveal aspect due to epiretinal membrane with different spots of epiretinal membrane around the hole. So this is a membrane, this is a type of membrane, and you have to operate them and they will go better. But if it's a lamellar hole, it means an atrophic evolution of the fovea, secondary to macular edema most of the time. So there is a thinning of the tissue, and if you operate them, you increase the thinning and you often increase the drop in vision.
So if I understand correctly, you would always prefer to peel ILM and do gas tamponade in these situations, is that right?
You mean if I peel the ILM in which situation?
Edema plus another epiretinal membrane.
I don't use gas, but I know that some colleagues do use gas. I have no opinion on that.
Sure, Sylvia?
A short comment. In this condition, I always look for a McTell type 2, because this anatomic configuration with this lamellar thing, I look whether there's a grayish ring or something hints on that, and then that changes the whole decision, pro or against surgery, because then I have a neurodegenerative disease.
Sure, thank you. Jerzy?
The first question is it symptomatic or asymptomatic for me? Because if it is symptomatic for the patient, I would go forward and do vitrectomy, of course, but if it is asymptomatic, I would just observe the case. That is the first issue. The second, that lamellar macular holes, we presented several papers published by Zofia showing that pseudo-hole moves into lamellar macular hole during the time course, and confirmed that with spectralis OCT, and looked on several cases of so-called non-full thickness macular holes, and in all of them we found epiretinal membranes. So actually for us, presence of lamellar macular hole is just an epiretinal membrane. If it is symptomatic, we do vitrectomy and ILM peeling. If it is asymptomatic, we just observe. No gas, no air, no tamponade. It is just epiretinal membrane surgery, and we also published our results, which were very good in those eyes. Of course, you must do very careful ILM peeling, and during ILM peeling, you will see that there is a hole in the center of the ILM because the origin of the disease is removal of some traction, of a small piece of ILM by the traction. And a secondary issue is epiretinal membrane formation on the retina. So if you do vitrectomy with ILM peeling only, be careful not to tear and not to produce iatrogenic macular hole, because if you do aggressive ILM peeling, you can produce iatrogenic macular hole, but it did not happen in our department until now.
Sure, Klaus.
We know that in these cases you cannot improve the vision. If you operate on them, the vision stays the same. So it makes sense to do surgery if the patient had had recent progressive loss of vision. And then the idea is to stop it. But if it's been like that for months or years, there's no point in doing surgery. So symptomatic in that case means progressive symptoms.
Of course. And do you think that it's a good idea to put tamponade just to reduce the possible risk of full-thickness macular hole when you don't have the facility of intraoperative OCT?
Never had a macular hole develop out of this, and to me, tamponading was a no-brainer.
Sure. Okay. Yeah.
Make a comment on formation of macular hole after peeling of ILM in a cystoid macular edema. Actually, this may be sometimes a solution, not a problem, because I have watched a presentation on doing cystectomy to convert a cystoid macular edema into a lamellar hole by doing the unroofing of the taking the inner part of the retina. That was presented last year in AAO in my coolest video session. So in the lamellar holes usually do not progress, and if you remove the ILM and the posterior hyaloid. So it's not so big problem when you unroof the inner part of the retina. But if you are dealing with optic pit, a macular detachment secondary to optic pit, which has outer retinal layer defect already, and if you peel the membrane, if you peel the ILM, it will cause a full thickness macular hole because you already have a outer retinal layer defect. Then you may end up with full thickness macular hole. That will be a problematic one. But for the others, you usually have just inner retinal defect, and if you put just some air or gas together with it, it won't cause formation of a full thickness macular hole.
Thank you. Yeah. Okay, so quick. Oh, sorry, Steve. Yeah.
Just real quickly, I've been presented a number of cases in which they're lamellar macular hole with an epiretinal membrane, but it looks almost like schisis that is in the middle nuclear layer. So as if the outer nuclear layers and the photoreceptor ellipsoid are intact, but almost looks like schisis. And when you do OCTs through this, you don't see the typical cystoid kind of formation that says that this is macular edema, but it's almost like a schisis that can go 600 or even 1,000 microns out from the center. Have any of you operated on these, and what do you do? Do you just do plain ERM and ILM peels? Do you use gas? What do you do here, and what do you think are the visual results? But these are some peculiar cases that I was going to try to present, but...
Yeah, you should. I do the same thing. My concern in those patients that have a lot of schitic type changes is that they can remain postoperatively, but I describe that to the patient and I describe it preoperatively to them that I think these schitic type changes may remain for some time and they're difficult to get to go away, but all of them have gone away eventually. And some of them I leave alone, some of them I've tried to treat with other substances like steroids or Avastin to try to think that I'm doing something, but I'm probably doing nothing. I'm probably just treating myself. I do. I still do. And sometimes the schisis still remains.
Okay, so with respect to time, we need to move on. So, Ferenc, what would you say to the supporter of EVS guidelines?
Well, this is very simple. The diagnosis equals one kind of treatment. There's no exception. I used to make a distinction between me being able to see the retina in an endophthalmitis case, in which case I was willing to wait with very close observation. But that was a long time ago, and then I stopped doing that. So if the diagnosis is endophthalmitis, then the treatment is vitrectomy, period.
Hooray. Okay, so that's your video, Ferenc?
Well, this is a very easy case because this is a trauma case. This is 3 weeks after the trauma, so in this case you don't have a question whether you would do surgery or not. And as you could see, the previous surgeon closed the corneal wound but did not close the scleral wound because the conjunctiva was not opened. And of course the cornea was very poorly sutured, so and the patient had light perception vision. So in this case, there was no question what to do. You had to do vitrectomy with a temporary keratoprosthesis. But I did not expect, in this case, again, we are 3 weeks after the trauma, I did not expect this eye to have endophthalmitis on top of everything else. But the patient did, and so a little bit of open sky vitrectomy is then followed by almost full vitrectomy. And the reason why I selected this case is, one, to show you what happens if you don't go in early. Of course, you must open the conjunctiva. But the real reason is to repeat what I said yesterday about the posterior hyaloid. This is 3 weeks after the trauma. There is no PVD. And if you don't do full vitrectomy, you will leave the pus that you can see sitting in the middle, a macular hypopyon, destroy the macula. You can expect very little visual improvement after all this because this pus has been sitting there for weeks, but still you give a little bit of a chance to the eye. And you can see this was a very long surgery because those colonies of bacteria had to be removed. The patient had 9, if I remember the number correctly, 9 pieces of glass inside the eye because he left his car through the windshield. And of course you had to put a corneal graft behind as well. So we are not talking about traumatic endophthalmitis in general here. We are talking about eyes with postoperative endophthalmitis. But the point I want to make is, for me, any treatment for any condition must pass not just a statistical or level 1 evidence test. It has to pass the common sense test. So I never for a single day followed the EVS because it does not pass the common sense test. To leave pus bathing your retina makes no sense. So even before I realized why the EVS came up with the conclusion that it did, I still continued to do vitrectomy for these eyes, and I never changed. But the beauty of going in early before you get to this very late stage is that it's actually a very easy surgery with very low complication rate.
Thank you. So we're moving to a mystery situation.
Well,
sorry, Steve.
I'm sorry, I don't mean...
You can just say.
Okay, just very quickly. I agree, Ferenc, with your immediate indications for vitrectomy. Here's my question. If we're talking about postoperative endophthalmitis that starts anteriorly and goes posteriorly, very often the attached posterior hyaloid can actually protect the macula because the inflammation gets caught in that gel. But I'm going to ask you, how do you operate on those that have a PVD already so the inflammation is puddled against the macula, the inflammation and pus is clotted against the macula? I think if we leave this, we are inviting macular purulent necrosis. So I try to go after it, but it's not easy. How do you attack these? Anybody?
You're absolutely right. If you wait until later stages, it is difficult. So I can show you video after video when I had to actually switch from the biome to a contact lens and aspirate that very fragile retina very carefully. And there may be a point where you have to stop. I cannot say at what point. I mean, this is not an objective measure. But what I can say is that I do remember I did my very first vitrectomy for endophthalmitis in 1985 with extremely primitive technology. But because I'm doing so much trauma, the presence of vitreous on top of the posterior retina has always been a favorite topic of mine, and I paid a lot of attention to it. So I can say honestly, I have never seen an eye with endophthalmitis with a PVD. It is a vitreoschesis, just as I showed yesterday with the retinal detachment. So, yes, you are correct in a way. You have some cushion of vitreous sitting on top of the retina. But I don't think that's enough to prevent the harmful effect of the pus destroying some function of the macula. Because let's recall this. When you have pus in the eye and you inject antibiotics, and you're fortunate that you chose the one that actually kills the bacteria, it's still not a cure for the problem, because the problem is not just the organism. The problem contains enzymes and toxins that the dead organism will still release and cause damage. So cleaning the surface of the pus and then the underlying vitreous, which must have some of this entered into, I think is the key to restoring macular function as much as possible.
I agree with you entirely. The only point I wish to make is in post-cataract extraction, awfully this is an elderly person with a PVD. You're right that most of the infectious inflammation with all of those necrotizing enzymes are in the gel, but I've seen then after I do my gel vitrectomy, it's puddled against the macula, and I just ask, what's the easiest way to try to remove these? I try to suction them, but I'm just scared to death of the necrotic retina that underlies them.
Yes, and that's why I said, doing surgery at a later stage, in other words, the ophthalmologist sees the patient with a developing or early endophthalmitis and say, okay, this is now almost normal, so I will just inject. And the problem is the disease may very well continue, and sometimes it's a fairly rapid process. So by the time surgery is done, it becomes a lot more difficult surgery technically with a lot more risks. So that's why I said make an early diagnosis and don't wait, but do an early vitrectomy. Again, going back 21 years, I have never had to go back for an endophthalmitis recurring after a full vitrectomy. Never.
And
Okay.
if any situation asks the question, what if it was your eye? I think it was this one. Would I
Yes.
like to walk out of a clinic with pus in my eye? Never.
And I highlighted a lot of limitations of EVS and a lot of unnecessary training biases yesterday and unavailability of theater access, logistics issue. We are not here to discuss those things. That's the job for technicians and manager. We need to do the best things for our patients, and that's exactly what we would like to have it for our eyes. Ahmed.
I think we're naming things differently. For example, you referred to the study by Frank Kuhn and Gianpaolo Gini as one of the important evidence that vitrectomy is better, right?
No, that was not the point. I put everything together because I know the methodology in that study.
No, if I can continue, I'm saying that in this study actually, as I understand, as I read it several times, you've treated patients with antibiotics, and after 24 hours, when they did not improve, that was published in, that's my reading. And the other thing is that also we're talking about early vitrectomy. People are talking while they're waiting, they give them injection of levoxin or moxifloxacin. So I think we're not talking about early vitrectomy. We're talking about earlier vitrectomy, about after intravitreal antibiotics.
Now, what I said in the study was and this is again what I used to do, and as I said, I stopped doing this.
But
I don't go
these,
2 ways.
The published ones are for this protocol, right?
Yes,
Yes.
but the protocol was not quite what you said. So what I said was, if I see the retina, so in other words, we are at an early stage, then I was willing to wait 24 hours after antibiotic and corticosteroid injection. But during those 24 hours, the patient is woken up at night hourly. So there is somebody in the hospital who will go to the patient, wake him up, and say, did it get worse? If the answer was yes, that's where vitrectomy came in. And if it did not improve after 24 hours, we went to surgery, even then.
Sure, but 24 and 30 hours are not very different, because if you look at the EVS, they operated between 30 and 60 hours. So I'm just saying that maybe naming things, we are just naming things differently. But it seems that we are all probably talking on the same thing, really.
But not exactly. You know, the highlights of the limitations of EVS yesterday I mentioned, the specific point. I'm sorry for boring the same point again, but it's, you know, the protocol of EVS said in vitreous TAP group that the vitreous biopsy was accepted, even if it's a vitreous cutter.
I don't want to waste time and...
Exactly. So the point is that, you know, that limitation has screwed the outcomes exactly on the vitreous TAP side. And then the secondary procedures, you know, 44 eyes out of 420 had second procedure within 7 days of trial entry.
7%.
Sorry?
That's 7% patients
So
were
what?
injected.
7% is
it
high.
It means that if you treat, 100 patients, only 7% of patients would need repeat injection. But anyway,
Ahmed, with due respect, I see the point here that it's the influence of a uveitis specialist training, not a vitreoretinal surgeon. I mean, with due respect, I'm saying that, but I think that can be the reason. If you do loads of primary early vitrectomy, and if you compare the outcomes, then you will see that, you know, why on earth I was arguing for so many years on the other side. And I've discussed with Farang, I mean, he's the god on this topic, but I consider 5 experts in the world for endophthalmitis, him, of course. Then there's somebody called Thara Prasad Das in India. Then another person in Singapore called Lingam Gopal, and William Miller, and Harry Flynn. And I asked a simple question, that if it's your eye, what you're going to prefer? And everyone else, except Harry Flynn, said primary vitrectomy straight away. Of course, they understand the issues about logistics, but this is what we are trying to say, that what should be our aim? How can we change the system, wherever you are in the healthcare system? That should be the aim,
That's
because
fine.
you don't want
I think
to
we agree to disagree, that's fine.
I must make one comment here. Because when I started talking about this very early after the EVS, I had to be put up with a lot of attacks, let's put it this way. And I remember I presented this, and Harry Flynn was the chairman of the session. And he asked very nasty questions. He's a very nice guy, but he asked very nasty questions of me during the talk. After the talk, I went to him privately, and I asked the same question, but slightly differently. I described the case which, according to the EVS, should have been assigned to antibiotics only. And I said, this is your mother, not your own eyeball. So if your mother has this and this, what would you do? And he said, I think in this case I would do vitrectomy. And I said, thank you.
And as we know, there are a lot of political issues even at the time, and then the personality of the chairman also. We can't go on those details on a public platform, but that's completely out of time. It's Bronze Age study, and we should not follow it. Quick point.
Can I have a word? Because some of those cases I did as well. I will tell you the experience back in those days. I remember that it was really going against the tide. I was in England at that time, one of the stages of my life. And I remember my registrar saying, but Mr. Genie, have you not read the EVS study, which I had not read. And I was happy that I had not read it, because I remember this was a macular hole case, which I had done the day before with, well, those days we used platelets, whatever, so autologous serum, and it developed endophthalmitis because the lab obviously did not know how to handle the blood. And I did vitrectomy, or rather a washout at that point immediately. And so I was asked why I did something which I was not supposed to do. I always did vitrectomies whenever I had endophthalmitis, and the results were always very encouraging. But you had to fight against the establishment. Plus, what Ferenc and most of you said, the equipment was lacking. It was dangerous even then, going in an eye with a 20 gauge, and you did it with a lot of apprehension. Today, the approach is very different because you know so many more things, and also because the equipment is different. So if I have an endophthalmitis, which I did just a couple of weeks ago, someone had an intravitreal injection and developed endophthalmitis, I did not wait. I got the patient at 3 p.m. and he was in theater at 6. Because a few months before that, I had gone through the same experience, and waiting overnight changed the picture completely. Completely. The patient could see light, he just had pain. I waited, did not give antibiotics, my mistake probably, but theater was not available. Did bring them to theater 8 o'clock in the morning the following day, and it was a completely different eye. So my idea, do not wait. Just go in, do it. We do vitrectomies for floaters, for God's sakes. We're not afraid to do vitrectomy for floaters. Why don't we do it for endophthalmitis?
Excellent. Steve.
Just real quickly, too, and Ferenc, you'll be happy to know that Harry Flynn, myself, Colin McCannell, a bunch of us said the EVS needs to be restudied. Based on all of these things, we've got to redo it. The DRCR network has been reluctant to do this. I guess we've got to take over and do it. What about endogenous endophthalmitis, where the infection is spread directly to the choroid outer retina, photoreceptor inflammation in the macula? What's the role here of vitrectomy? What do we do? How do we fight this the best? Do we do systemic antibiotics with it? Any ideas about endogenous endophthalmitis?
Very quickly, but before that, if I can say, as we discussed yesterday, I think for EVS2, I think we can't completely negate the surgeon factor issues and a lot of other things. So even after EVS2, in 10 years' time, we might be discussing the similar things, and we don't need that. I mean, we just need to follow certain logic and a lot of evidence, whatever we have. That is more than enough just to follow what Ferenc is saying for a long time. Ferenc, quickly, endogenous, please. I just think that it's vitrectomy primary for that as well, but obviously
Yes,
he's the boss.
Yeah, I do too, but the prognosis is very poor,
Quickly.
no matter what we do. And I always use systemic antibiotics, regardless of which kind of endophthalmitis. Because this is a killer disease and we have weapons, I think it's a lot more important to use antibiotics in these cases than using it prophylactically after a cataract case.
Okay, so quickly moving to now the prophylaxis in relation to intravitreal injection, and here is the person who has the largest series in the world, Abdis Bawsar from Minneapolis, Minnesota.
Thanks, Malhar. Thank you, Malhar. Just a quick show of hands. How many still use antibiotics for intravitreal injections at any time, before, after, during the injection?
Okay, let's hope up this changes.
20%.
Right.
Okay, so let's see if we can convince you.
Right.
We've been talking about not using antibiotics for more than 10 years at the Academy, at the American Academy of Ophthalmology, with my first presentation with a very small series. We grew that series, and eventually, after many years, consecutive series of patients, 18,000 injections. And let's move ahead. My technique is very straightforward and very minimalist, so everything is geared toward minimalism, and that technique is the same technique we ended up using largely in the DRCR. I use a simple tray, everything's on the tray, it comes in and out of the room as we go along, and someone can move that ahead for me. Non-sterile gloves, proparacaine or tetracaine and or both drops, topical povidone iodine, sterile speculum. I used to use a sterile scalper in the early years, haven't used one for almost 10 years. No use of topical antibiotics, of course. And someone will have to advance the slides because it's not doing it. Technique, also important, I mark the eye. It's a surgical site. Every patient gets marked with the drug and with the eye of injection, just with a little piece of tape over the eyebrow. to avoid wrong site injections. This is a consecutive series over 3,000 patients, 18,000 plus injections, and one case of endophthalmitis. The patient happened to have worn an extended wear contact lens. I don't know if that had anything to do with the endophthalmitis, and my guess is it probably did not. 8 cases of retinal detachment. That was one of the other significant outcomes that we looked at. And bottom line is, I never have used antibiotics for 19 years in intravitreal injections. We developed much similar protocol in the DRCR, although in the early years we allowed surgeons to use antibiotics, and so now I'll present some of the results that we have from the DRCR net. And the advantage of the DRCR network is that we have consecutive clinical trials in which the PrEP protocol is the same. And to date, actually not to date, but this is the last time we looked a few years ago, in just a few months you'll see the latest data come out, but 24,000 injections so far in this series, 13 injections did not have povidone iodine. So one of the other big things that we looked at was not using povidone iodine and the impact of not using povidone iodine. It was, of course, a protocol violation because if a patient was allergic to povidone iodine, they were not supposed to get injections, or you had to use povidone iodine anyway and give the injection if the patient wanted to be in the study. 15% of the injections, one back, were treated without povidone iodine, developed endophthalmitis, so the rate is extremely high. Eventually, those 2 eyes after 13 injections did get endophthalmitis eventually, and that's 100% of the eyes eventually developed endophthalmitis if you don't give povidone iodine. So in those patients that are allergic to it, I use it all anyway. Rates by antibiotic use. We did have an opportunity to study this in our trial. 6 eyes or 6 cases had endophthalmitis and did receive topical antibiotics. 3 cases did not had endophthalmitis who did not receive topical antibiotics. So although this was not statistically significant, it parallels the results of many other large-scale clinical trials, or rather retrospective studies. They're large-scale retrospective studies that have demonstrated similar results. For some reason, the series of patients that get topical antibiotics seem to have higher rates of endophthalmitis compared to the series within those series that do not get topical antibiotics. I don't know why that is, but one of our hypotheses is that it's just extra manipulation of the eye, and that's why we go to a more minimalist approach. We have now subsequently changed the DRCR protocol to forbid the use of antibiotics, period. And that's based on all the data that we have to date.
Just quick 3 points of this. So this injections, all the data from RCTs for the last many years have come from US only. So the issue of the clean room, the rooms used for intravitreal injections, what was the condition of the room? So it's like carpeted, non-carpeted, outpatient office procedure?
Yeah, those are very interesting questions because of prior presentations during this meeting. In the DRCR and in my own series, all of those injections are administered in the office setting, in the standard office setting, standard office examination rooms. The majority of centers in the DRCR are actually non-academic centers. They are private practices, just like my own. And in those cases, it's in the normal room.
So it's a carpeted room.
It's a carpeted room. There's no control over masking, withdrawing of talking, or use of sterile gloves. And so that's the results we have from the reason that these results, I think, are more significant is because they're done in a controlled setting, in the setting of consecutive randomized clinical trials. Now, the randomized clinical trial was not to study endophthalmitis. Many years ago, when we designed Protocol I had proposed embedding an endophthalmitis study within the trial. We decided not to do it at that time because we didn't think we'd have big enough numbers. But as the network has gone on, we are increasing our numbers of injections, and we've now got more than 20,000 injections, and now it's pushing 30,000 injections. And it would have been interesting to have done that prospectively. Without that benefit of prospective, the next benefit is randomized clinical trial setting where we're capturing every patient and every outcome. That's more superior than a retrospective study.
If I understand correctly, the exposure time, and that's what I prefer for the povidone iodine on the conjunctival surface, if you do it for 30 seconds, that's enough. Is that correct?
So our recommendations from the clinical trial protocol are that povidone iodine has to be present for a minute. When I poll investigators within the network, that time is significantly less than that. But the definition of povidone iodine present by the protocol is 1 minute.
No, but if you go back to the original paper, that mentioned 30 seconds. Is that not right?
It was 1 minute. Now in my
No,
series...
not for the DRCR, but the
No,
original
1
povidone
minute.
iodine.
It's always been 1 minute.
Steve.
Can I give some additional information to try to convince you all to stop pre- or post-operative antibiotics? From the information from Stanford and from Jim Kim, pre-operative, using 3 days of topical antibiotics did not change the spectrum. In other words, povidone iodine, even when given for 1 minute, does leave some bacteria still on the bulbar conjunctiva that can be cultured. This is not altered at all, the spectrum of that is not altered by any 3 days of antibiotics prior to giving the injection. If you use 3 days after the injection to give antibiotics, what Jim Kim has shown is that when the patient comes in the next time to get their injection, you now have resistant bacteria to that antibiotic, not only on the eye, but in the nose. I think we're inadvertently creating potential for sinusitis and pneumonia in these elderly patients that have poor repair, etc. So we're trying to convince people not to use either pre or post-injection antibiotics. Just the povidone iodine exposure for a minute.
Steve, have you tried convincing the ESCRS of these arguments? Okay.
Got it.
That'll take a few beers.
And I'm sure, as Dr. Ducournau would note, the pressure from industry would be too great to make that change, and they will use your terms if you tell them to stop using antibiotics. One
Up this
question.
quickly. If you may want to ask again, show of hands, whether you have been successful in changing.
Would anybody change their opinion and not use antibiotics? Anybody? Just one. One person. All right.
Excellent.
Woo, success.
No, I don't use it for a long time, and I don't use it for sutureless vitrectomy also. Post povidone iodine. Of course, post-op antibiotics because of the unnecessary legality aspects, but I'm not convinced about any evidence. Last point, genuinely last point on that. If, again, we need to repeat, and let's say together. If a patient is allergic to iodine, what do you do? Let's say together.
Yeah.
Povidone iodine. So you just need to do that.
Oh, wait. There is no such thing as an allergy to iodine, because if you
Exactly.
had an allergy to iodine, you'd be dead.
Exactly.
So there was an earlier comment about
Right.
oral strep species, and I don't know where that data came from, but that's certainly not the case for our series. And the published series and my own personal series, that was not the case. We have the culture results from all of those cases, and there was only 1 or 2 that were culture negative. All of them were culture positive, and the majority of species were coag negative staph.
Okay, genuinely last video. This is Jersey's video, and I would like to say that I agree for the inverted flap technique on a situation like that. So, yeah, please.
Thank you. It is a child, a 9-year-old child with morning glory and optic pit and retinal detachment caused by them. The case was operated elsewhere some weeks or maybe 2-3 months before, and here you see ILM was already peeled on the center, and fovea is close to the margins of morning glory or optic disc. And in this specific case, this is a new technique which I suggest may be used. I peeled a flap where I could peel, because in the center it was not possible because already it was peeled. And I introduced the ILM into the optic pit. We call it stuffing of the optic pit. And some laser was additionally added, but you see fovea is just at the margin of the optic nerve, so it was not possible to make laser in fovea, and air injection followed. And already 7 days after the treatment, retina was completely reattached, no maculopathy, and it persisted for about 6 months until now.
Excellent. So that brings to the conclusion of this symposium. Thank you all very much for being here, and thank you, friends and panelists. Okay, we have another Chile at American Society of Retina Specialists in August and in Academy in October. So if you're attending, it would be great if you can join. Thank you.